We're going to talk about that, why it matters. We're going to talk about how you apply those concepts, how do you get to the evidence in your practice. And then we're actually going to take a hands-on look at a few resources that you can use as you go through your practice that can help you provide better evidence-based care. Now, is everybody here pretty much ETSU? Is it? Okay. So we'll look at a couple of resources today that are subscription-based that the library pays for, but as long as you're here, you'll still have access to those. We're also going to talk about a couple of free resources that you will continue to be able to use for evidence and practice as you move throughout your career. So, what is EBM? And this is, that's how you'll hear it described as EBM a lot. People abbreviate it that way. That stands for evidence-based medicine. Sorry, I'm going to fuss with the microphone for 1 second. It might make a bad noise. Okay. So the official and kind of standard definition of evidence-based medicine is what you see on the screen. Conscientious and explicit use of the current best evidence in making decisions about the care of individual patients. So that doesn't mean that it's cookbook medicine. It doesn't mean that one size fits all. It means that using your clinical judgment and using what you know about the patient and the patient's preferences, their values, what care they're willing to accept, you combine those factors with what you see from the medical evidence in order to deliver care. I do want you to be familiar with this person's name, David Sackett. He's basically the godfather of evidence-based medicine. And he has a really great book on the topic. It's listed. If you didn't get a handout, there should be some up front. If we're out, you're welcome to email me and I'll send you the file. And the citation for his book is in there, and you can look at that. And I really recommend that as an intro to this concept. So the question, when you hear, especially when you're new to medicine and you haven't been around for 100 years to get a little bit jaded and cynical yet, people always say, well, isn't evidence-based medicine what we're doing now? Like, why am I in school learning stuff if care is not evidence-based? What am I even learning? The actual evidence about this says that most people are not. The Institute of Medicine released this really groundbreaking report in 2001, which has been a little while now. It's called Crossing the Quality Chasm. If you haven't seen this, you should. It's a free report. You can look at it online as a PDF. It doesn't cost you anything to get that. And what they found was that once medical providers know from the literature what is the best thing to do, it takes about 17 years on average for that to actually make it into practice. So you see, as you go through your day, you learn about things, you'll see things in textbooks, you see news stories that say, hey, there's a breakthrough treatment, we know this needs to happen, but it might be over a decade before what we know needs to happen is actually happening. This didn't make it into the slides because it just came out in this past few weeks or a little bit. The Institute of Medicine has issued another new report that's essentially a follow-up on this, but it's really focused on diagnostic error. And they're saying also that most American patients will experience at least one diagnostic error in their lifetime, that 5% of U.S. adults seeking outpatient care every year experience a diagnostic error, and that diagnostic errors account for up to 17% of adverse events in hospitals. So getting the right care to the right patient at the right time based on the evidence is something that's important, and it's clearly from the statistics not something that we're reliably doing. This new report on diagnostic error also makes a point to note that many clinicians may incorrectly assume that a patient has a psychiatric or alcohol or drug problem, and they'll diagnose an issue as a psychiatric problem when there actually may be another serious illness involved, such as a metabolic abnormality, a head injury, or other things that can cause some of those same symptoms that will be passed off as psychiatric. Just to further hammer home that point that what the evidence says is not necessarily what we're actually doing in practice, this is another study from 2000 that once it was clearly in the evidence from randomized controlled trials, so your really good level of evidence that you want to rely on, once it was clear from the evidence that thrombolytic drugs needed to be given when people were having a heart attack, it took about 13 years for the majority of clinicians to actually be providing that care. So that's not necessarily an example from your specialty, but I think it does hammer home that this is it takes a really long time for what we know works to make it into practice. And what that means for you is that not only is what you know out of date, as you go through your practice, throughout your career 20 years from now, what you've learned now may be very out of date. It also means that the other experts that you talk to for a consultation, you go to a colleague, even a senior colleague, and say, hey, what do you know about this? Their knowledge may be out of date as well. So you really need to be careful about and be thoughtful about, is this expert opinion, which is considered the very lowest level of evidence, or is this really evidence-based? And if you all have questions as you go, we're kind of a small group. Feel free to interrupt and put your hand up and ask me anything. We'll have some more time at the end, I think, to look at questions too. So there are generally 5 steps for evidence-based practice, and there's mnemonics for a lot of this stuff, which I think helps. And so it's generally considered the 5 A's of evidence-based practice. You assess the patient, you ask the question, acquire the evidence, appraise the evidence, and apply it using your clinical expertise and patient preference. We're going to focus today really, for the most part, on asking the question and acquiring and appraising the evidence. So this is a format that you can use for asking clinical questions. Before you can look at the evidence, before you can even figure out what does the evidence say I should be doing in this patient situation, you need to figure out how to ask that question so that it's actually answerable, which sounds like a little weird until you get used to it. But I want to give you this example here. You may say, for example, does an antidepressant work? Well, what does that mean? That's not a good enough question for you to be able to answer it from the evidence. Work for whom? What does working mean? Compared to what? And what outcomes are you really looking at? What do you want to assess? Is it enough to say somebody says they feel better? Do you need to see the evidence that it improves mood on some scale? Do you want to see reduction in suicide attempts? What are you really looking for? What are you really trying to affect? You can't ask that question of what works for this patient without really knowing what all your options are and what the outcome you're trying to achieve is. So this acronym, this PICO or PIPO, is intended to help you do that. So P stands for patient population. So as an example, you could look at a pregnant woman with a history of major depression, currently in psychotherapy and taking 50 milligrams of sertraline daily. You might be thinking about it and saying, okay, should she continue on this drug throughout her pregnancy or not? So the intervention that you're looking at might be the 50 milligrams of sertraline. Well, compared to what? You might want to look at whether it would be better to wean the person off and continue their psychotherapy. This is just an example. There's many others that you would come across in practice. But what outcomes are you really trying to affect there? Are you looking at her adequate relief of her depression? Are you really just trying to avoid neonatal respiratory distress when the child is born? Are you looking at effects on possible lactation after the birth? What are the issues that you're actually concerned about, and how are you trying to affect those as you go? So a question like, is sertraline good for pregnant women? That's really too broad, and you're never going to be able to really get at an answer to that directly through the evidence. You need to know kind of all the factors that you're looking at. And this is really oriented towards therapies and interventions. There's not a good version of this PICO format that's for diagnosis, but I think you need to think about that as you go through diagnosis and try to avoid diagnostic errors too. Am I looking at all the possible factors that need to be considered? So, starting with, is everybody okay so far? Questions about that process or what evidence-based medicine means, anything like that? Okay. Your number one tool for practicing evidence-based medicine, evidence-based psychiatry, is going to be PubMed, which includes the Medline database. There are a lot of different formats for that. That database lives in a lot of different interfaces. I think it's better for you to learn it through PubMed because it's free, it's provided by the government. So anywhere you go throughout your careers, you're always going to be able to access that. Other proprietary databases you won't necessarily have, so if you learn it in kind of one interface, you might have trouble translating that to another. And we do offer in the medical library more hands-on, in-depth, one-on-one trainings on using PubMed. So if after this you kind of think, okay, I want to learn more about that, feel free to email me. In the handout, there's email addresses. You can follow up with us, make an appointment. Or if you have a specific question that comes up throughout your studies or care, like I'm trying to find the evidence on X, that's a really good time to come and ask for help, because then we can work through the question with you and show you, like, here's what you need to look for, here's how to kind of pick the right articles and things, how to evaluate those. I do want to suggest that you get into PubMed and you set up a free MyNCBI account in there. It's a free user account, but what that allows you to do is save your searches, get alerts, so if there's a specific issue or topic you want to keep up with, you can set up a search on it and then set it to email you every time there's something new, or once a month or once a week, and that can really help you as you go forward maintaining that current awareness. Otherwise, it's really hard. You know, PubMed, as of this year, has something like 25 million citations in it. It's better if you can kind of find exactly what you're looking for and then have it update you as you go. That'll also let you save citations, so when you don't have a lot of time and you can just find that one thing, you can save it in there and then you can come back to it later. So let's actually get out of the slides and look at PubMed for a minute, because I want to show you something. Who all has actually searched and used PubMed before? Pretty much everybody, hopefully, at some point? Okay. If you haven't, it's no big deal, but you should play around with it. And I want to show you a trick. So you have a search box up here, and it's really tempting to use this just like a Google search, right? It's a plain search box, just type stuff in. So say we want to do like SSRIs and pregnancy. We can just type that in. That's fine. If we want to do SSRIs and breastfeeding, we can just type that in. We're going to get some good stuff back right away. Here's one. First thing, sertraline and breastfeeding, review and meta-analysis. We'll talk about levels of evidence in a minute, but when you see that meta-analysis or you see systematic review, that's probably going to be one of your best high-quality things you can look at. But what you should realize when you do this is that PubMed isn't just doing a Google search and searching for the words SSRI and breastfeeding. If you look down here, it's actually transforming it into something very different. This is not necessarily what you would expect that search is doing, I don't think. Unless you look at this, you don't have any idea. But the thing I want you to realize is it's not completely reliable. It's not going to get everything on that topic. Does anybody see a concept that's really missing here in how it transformed it? Anything? Okay, so when I look at this, one thing I don't see anywhere is the word lactation. So I'm going to get all the articles now that actually say the word breastfeeding in them. I'm not going to get anything in there that says the word lactation unless it also says breastfeeding. So the point to that is that you can really miss a lot of the evidence if you're not thoughtful about how you're constructing that search. If you really just go at it like a Google search, that's great if all you need is one thing. Like if all you want is that one meta-analysis that came up to the top, fine, you're done, no big deal. But if you really need to make sure you're getting a balanced view, you're getting multiple studies that may conflict, you're getting everything, if you want to do your own systematic review, then you really need to come back and approach this a little bit differently. And PubMed does have a system of terms you can use. Has anybody, let me actually show you one. You may have never looked at this part, but once you go into the citation, you have this list of subject terms that's been applied. And so the National Library of Medicine has gone in and applied these terms to every citation in this database, and you can use these to kind of help you find more things, help you use the right words. And so what I see here is that lactation has its own term, and I actually want to use that in a search. And I'm not going to go through the detailed process of building, a really complex search in here, but the point is I want you to see that there is a difference if you use it in different ways, that you could be more thorough or less than thorough with the words. I went through and did a comparison, just the SSRI and breastfeeding versus a more complete search using the lactation term as well. There were about 75 additional articles that came up when I added that term. That's a fairly small topic. If you go into something broader, like if you just put HRT for hormone replacement therapy in here, it doesn't map to that at all. It only brings you articles that actually use the acronym HRT, and you miss something like, see I have a note about it, you miss 12,000 articles on it. Now you're not going to look through 12,000 articles because that would be absurd and you don't have that kind of time. But the possibility that the information you actually need is in that huge set that you missed because you just typed in the acronym is pretty large. So just kind of be careful about that and think about it as you do your searching. Questions about PubMed? Anybody? we definitely can do more detailed training. We can do some more examples at the end depending on how much time we have and kind of work through a more complete example. But I do want to show you some other resources first. If you're at ETSU, you have access to a database called Psycinfo. Has anybody used that? Okay, so very low familiarity with Psycinfo here. It's exactly what it says. It's info in psych. It does tend to be focused a little more towards kind of psychology and some of the social and behavioral sciences. And there is a fair bit of overlap with PubMed, particularly on drug studies primarily. But I think anytime you are looking for the evidence on a psych topic and you have access to Psycinfo, you really need to be looking at this database. So we can do something like this again. We can just put in sertraline, and then you can actually combine things here. We can say breastfeeding or lactation, and then you have some options to say, okay, I actually only want that if those words appear in the abstract, which is going to help you narrow things down a little bit. And this will also let you use some different subjects headings, but with this one, you don't need to do as detailed of a search. You have some other limits down here as well, such as publication year. I would really caution you about date limits. I think doing date limits with your searches is kind of contradictory to the whole concept of evidence-based medicine. There is a pretty famous case, which of course I've forgotten all the details about now that we're standing up here in front of you. But for example, it was a university that was doing a trial, and they had some adverse events in the trial participants, and come to find out, it was well known that that was a possible effect of the intervention that they were doing. They just had not gone far enough back in the literature. They had kind of applied an artificial limit, and by doing that, they never caught that, yeah, some people in your trial are going to have this really bad outcome. And I think one of their patients, and if you want me to find the details of this case, I can go back and figure it out. But I think they actually had a trial participant die of this effect that was known. They just didn't go back far enough to actually find it. So I would advise against year limits unless you're literally just saying, I've been following this my entire life. I just need to know what came out in the last 6 months or a year or whatever. So you hit search on that, and you get your articles here, a little bit of an abstract. And for the most part, if you're on campus, you're connected to the network, or you're logged in from off campus, which you actually can do. If you're on our library website, we've added a link down here for off-campus users to start with your ETSU ID and password. That'll streamline a little bit your being able to get to all the resources we're providing for you. And you can go through, and a lot of these will have either just a link to the PDF full text or a link to, look in the library catalog and see more. Psycinfo, it's a fairly straightforward database. I think it's a little less complicated than PubMed, and there is a lot of overlap, but I do think that you should consider using that anytime you have a psych question. Let's see, we're a little backwards here. Okay, so you're not always going to have time to look through all these papers, obviously. As I mentioned, PubMed, it's 25 million citations. There's a lot of stuff in there. There's a lot of medical evidence being generated every day. And, going back to the Crossing the Quality Chasm report, this was in 2001. And think about how information overload, the amount of scientific literature being published, has only increased since then. I mean, you all have probably seen that. Even in 2001, they were saying it was impossible for any one clinician to, one, retain all the information necessary for practice, two, it was impossible for any unaided human being to read, recall, and act effectively on the literature that's out there that affects their practice. So don't feel bad about, I can't keep up with the literature, I'm behind, I don't, how is this changing, how have things been changing, especially as you all get into drug information and that kind of thing. Because that is changing constantly. Don't feel bad about it. You really just have to find some coping strategies. Some of those can be getting alerts, getting alerts from PubMed on topics where you need to look at. It can be doing searches for the current evidence when you have a clinical situation that you're not familiar with or you need to brush up on. It can be contacting a librarian for help. We can help you do that search, help you find and evaluate the evidence, and really help you make sure you're finding the right stuff to answer the questions that you have. So, but there are additional resources when you don't have time to go through all of those, PubMed and go through all that primary literature. Make sure you get the handout, because I just listed these here, but on the handout I have pros and cons of every one of these databases with information about what they're for and some comparison things. So there are summary tools. Who's used up to date? Pretty much most, okay. Dynamed Plus, those are very similar. Those are considered a point of care tool. They are subscription. We get them for you all right now. I think the hospital also gets up to date for the residents. And then, but once you leave an institution like this, you might have to purchase these for yourself. Let me just show you a quick thing. So more people are familiar with Up to Date, so I'm just going to show you Dynamed Plus real quick. We can do the same thing here. This you can use like a Google search, no big deal. So let's do that sertraline and pregnancy thing again, and hopefully I won't have typos everywhere. So you just put in the topic you're looking for, and it's usually faster than this. That's always awesome when the resource doesn't work in front of a crowd, and it'll work like every other day of the year except when you're showing it to someone. Okay, let's try. All right, Dynamed, we're skipping you and trying Up to Date. Maybe that'll be better. So I just put in sertraline and pregnancy again, and it's coming back with a few options. This is intended to just give you quick summary information. You can kind of look through here. If you want to explore kind of major depression and pregnancy more generally, there's some stuff there. There's some stuff about infant exposure and breastfeeding. There's some stuff about side effects. But really, risks of antidepressants during pregnancy is probably what the thing you would be most concerned about in this case. And then this is just going to give you some summary data on different issues. So like preterm birth. This gives you specific SSRIs. So you can come down here to sertraline, and it's going to give you just a brief summary, excuse me, from different studies. It'll give you citations. So it's kind of pulling from that evidence for you and kind of giving you that quick summary stuff. So this you could use more readily in kind of a clinical scenario when you just need to kind of refresh your memory real quickly. But I would caution you just a little bit about these summary tools. Up to Date, Dynamed Plus, Essential Evidence Plus is another thing we offer, because they vary in how transparent they are about, how recently has this been updated? What was the process for updating it? Because what you don't want to do is slide back into that expert opinion territory. So if you assign this topic to somebody, if Up to Date assigns this to somebody, there's a possibility that their bias could creep in as they're pulling the papers and assembling the summary information. So you consider them a starting point. Don't consider them kind of the be-all, end-all, everything about the topic. You still kind of want to follow through to the extent that you can to other resources. So you have those as what are called point-of-care tools. You also have systematic reviews, which is really kind of one of your highest quality levels of evidence. And we'll look at that more later. But what that means is that somebody else or a team of people has spent a great amount of time really methodically looking through the body of trials on the topic that you're interested in. And they've gone through and they've said, are these trials biased? Do they have results that are useful? How does this apply? The AHRQ ones, those are US government funded. Cochrane is more UK oriented. So this website is freely available. It's on your handout. But what you can do is just put in a quick topic. And the thing to remember when you're looking for systematic reviews is that they often encompass a lot of different things or interventions. And so your question, sertraline in pregnancy, that might not be the title of a review. But treatment of depression in pregnancy probably is, and it's probably going to address that drug inside it. So just kind of keep that in mind. You might not see it at the specific level that you would expect. So I just put in SSRI and depression on that one because, again, we wanted to go a little broader. There's a link. Let's see. So we have a few different options here. Oh, actually, I wanted to do pregnancy. Sorry. No, thank you. All right, so the first thing that comes up is this treatment of depression during pregnancy and the postpartum period. If you look at this site over here, you have the full research review. That's going to be the full systematic review that was conducted on this topic. You can go right to the web version. And then you can actually just search across the page. Actually, this is just the abstract part. But you can search in the book. And I'm just going to put in sertraline. And it's going to give me all these different options, but I can go into the results and see the details. And so I just clicked on details there, and it's telling me these tables. So I can get immediately to, for example, risk of persistent pulmonary hypertension with certain SSRIs. And that's going to give me a comparison right away of the rates for the various drugs. So that may help you compare things. And this is just one example of a topic in a systematic review, but they are very thorough. They give a lot of details. And they almost always will address harms, so they'll almost always have a bit that looks at adverse effects. We do have a few drug resources you can look at as well. And most people are probably familiar with Micromedics. If not, that's kind of a really good standard resource for complete drug information. What most people haven't heard of is a database from the National Library of Medicine called LactMed. And that is all about the effect of drugs in lactation. So that's something to consider as you deal with patients who are breastfeeding. So we can just type in a drug name here and click on it, and then it's going to give you the structure. It's going to give you a summary of use during lactation. And then if you want to go into the more details, it'll say, effects in breastfed infants, effects on lactation and breast milk, alternate drugs to consider, and then just some additional information about the substance and that kind of thing. But this is a really good resource that a lot of people are not familiar with. It's freely provided and has a lot of good detail in it. Let's see. So the kind of the last thing are guidelines. And is everybody kind of familiar with what a clinical practice guideline is? It's sort of just a summary of information. A lot of times they're issued by organizations saying, okay, here's our position statement or our guideline on whatever condition or whatever therapy. But they're not necessarily the best level of evidence. And when you get to guidelines, you really have to be careful because they're really varying quality and strength. Some of them, if you read, particularly sometimes from organizations, it may literally say it was committee-based or consensus-based. And what that means is a bunch of people got in a room and they talked about it and they said, yeah, we all kind of think X should happen, that is not really evidence. That is what a bunch of people in a room think. Others, such as the guidelines from the U.S. Preventive Services Task Force, the NICE guidelines out of the UK, those are pretty much always based on systematic reviews. So you can actually follow through to the evidence and figure out how did they come to this conclusion, how strong was the evidence, what were the concerns about bias in the evidence. So those are going to be more robust when those guidelines are based on a systematic review. So that's something you want to look at as you're trying to review the evidence. Appraising that evidence is a skill that takes a while to learn, okay? It's something you have to practice at, you have to kind of do hands-on. It's not something we can fully go over everything in this class because there's a whole biostatistics class you would need. There's a whole bunch of stuff you would need to really be 100% on appraising the evidence. But I wanted to give you some general guidelines. One, of course, is it relevant to your patient's situation? Think about that PIPO thing that I showed you earlier, and does it match? Was the study well done? Did they use appropriate methods? If you can read the study and say, yeah, but what about people who were also doing this that they didn't account for? That's going to maybe weaken their conclusions a little bit, and you need to think about that. Were their statistical methods sound? Was the study blinded if that's appropriate? Is it biased in some way? One thing you all are going to run into a lot in psych are the drug studies that have been funded by the drug companies. So obviously, the drug companies have an incentive to have research come out that kind of shows their product in a good light. And there's a concept called negative results, which is the idea that research results that don't put that product in a positive light are never going to be published. You're never going to see that because they're never going to want to have that out there. And so you really need to think about that. Is there a possibility that the research was biased because it's all pharma funded? Where does it come from? Who is doing the study? What ideological biases may they have as they conduct it? That's a really big issue and something you need to think about. And as you look particularly at drug studies, you need to look for the funding source. I want to also really caution you not to go by just a journal's reputation. You know, there's big journals in medicine and psychiatry everywhere. You know, if you get a publication into JAMA, you're really excited, and you know, because it's a prestigious journal to get a paper in. But the thing you need to remember is when you're looking at other people's publications in JAMA, is just because they're there does not guarantee that they're well done studies, that they're high quality. There was a pretty high profile retraction from that journal just recently. I mentioned in your handout a resource called Retraction Watch, which keeps up with scientific study retractions, largely because of fraud or some kind of misconduct. And there was a set of papers retracted from JAMA just recently for misconduct. And the editors don't always catch that. Some of these big journals have statistical editors too, who presumably are looking at the data and making sure this was done appropriately. But it is not a guarantee that it's a good paper. So don't ever get in the habit of, I'm just going to go read the abstract from this paper in JAMA, and I'm sure that that means that that's fine. One, it may not be. Their methods may not have been sound. There may be sources of bias. The other thing to caution you about when you're trying to practice based on the evidence is don't go just based on that abstract. To the extent you can access the full text, you need to do that. An abstract for a paper is really a marketing tool. It's going to tell you whether or not you want to read the rest of that paper. But I've been in medical librarianship for 12, 15 years, and I cannot tell you how many papers I've read where the abstract suggests one thing, and then you get into the paper and the methods and the conclusions, and you see, well, what they're saying here does really not square up with what they said in the abstract because there was some limitation, there was some other issue that they didn't reflect in that little summary bit. So you really cannot go just based on that as you practice. Just reading the abstract of a paper is not evidence-based care. So this is something I've been kind of alluding to throughout this talk, is there are levels of evidence. And this pyramid is kind of a generally accepted ranking of the types of papers and how strong of evidence they are. You can see that we're going from worse to better as we go towards the top of the pyramid. So expert opinion, so those, just what your colleague says because they think it's true, that's expert opinion. The guidelines that are based on a bunch of guys sitting in a room, that's expert opinion. That's a really low quality of evidence. That's not considered practicing evidence-based medicine. As you go up the pyramid, you get stronger. So you have case series, cohort studies. You guys are going to run into a lot of things that are just small case series or cohort studies, and that's not really a very strong level of evidence either a lot of the times. Once you get to RCTs or randomized controlled trials, a well-done RCT would be considered a strong level of evidence. That's what you want to look for as you're looking for things to base your patient care on. And then moving up the pyramid, you get to systematic reviews and also meta-analysis. A meta-analysis kind of goes a step beyond the systematic review and kind of pools all the data together from all the studies they've looked at, kind of turns that into a virtual, larger study and figures out, what can we figure out based on that. The caveat here is that a systematic review is only as good as the papers it's based on and the team doing the review. So if all the papers underneath it are garbage, it's going to be harder to produce something good coming out. And that a lot of times is why you'll have a systematic review that will say their only strong conclusion is more evidence is needed because they've actually looked at all the papers and figured out all these studies are inadequate in X, Y, and Z ways, and that's not enough to base firm conclusions on. So yes, systematic reviews are the top of the pyramid. That's your best quality, but still maintain that healthy skepticism about their methods and their approaches and make sure that they've reported those appropriately. Just if you want help later, if you need to talk about any of these things in person, if you want to sit down and have a hands-on PubMed session, hands-on Psycinfo session, get in touch with us. If you want a copy of these slides, I don't know if you'll get them from here, but you can email me and I'll get them to you. We're available to help with this kind of thing. The librarians can show you, more about how to appraise this evidence. There's a few references at the end, but really what you want is the handout because that's going to give you kind of pros and cons. So that's it for the slides, but I left a little time for kind of looking more hands-on or questions or more in any of the databases you want to look at. So what questions do you have, or what kinds of things are you coming up against where you think you need to be more evidence-based? Anybody? Is everybody just Friday, like we're just done with the week? Yeah.
Could you please use the microphone? Dr. Moore has requested that because we are recording.
So a question about the evidence of evidence-based medicine.
Yeah.
Is this generally a field that's continually evolving, or are there?
Well, in some ways, yeah, because it's really, there's only been an emphasis on it for about 15 or 20 years, I think. And that sounds probably to some people like a long time, but it's really not when you're looking at the big institution of healthcare overall. It is evolving. There are people who are critical of the concept of evidence-based medicine because they think it's kind of like a cookbook approach. But I think that's in the application. If you don't just look at things and say, I'm always going to do this for every patient with X. You really have to remember that the other parts, the other legs of that stool are your clinical experience and the patient's values. So, there's always been some back and forth and debate about that. There is another way it's changing is people just trying to take that broad concept and really explore it in specialties. So evidence-based psychiatry or evidence-based nursing or whatever it is. And that kind of progresses. And I think some specialties are easier or harder to practice that in. I think in psychiatry is kind of somewhere in the middle probably. So it is a concept that evolves, and one of the areas I think it should evolve is looking at that issue of the diagnostic errors. So evidence-based medicine, as it's been practiced and explained over the last 15 years, has really focused on comparison of interventions, right? Do I give you this drug or this drug? Do I give you this drug or no drug? Or do I give you this drug or tell you to exercise? And I think it hasn't really, that PIPO format doesn't really address diagnosis. It doesn't really look at how do I compare, is it possibly a head injury or a metabolic problem versus a psychiatric illness, and am I always getting that right? And so I think there's some work to be done there just to kind of build the frameworks around that. And if we can get it into a mnemonic, it's going to be easier for everybody. So I do think there's some work to continue there as well.
I just have a quick question for you. Yeah. I've heard people saying that in PubMed, basically anybody can put their articles there. And as far as for us that sometimes don't have too much time to actually critically appraise the article, how liable is that as far as using it as the primary resource?
So it's not quite accurate that anybody can put their article there, but PubMed they do not have an article level appraisal function. They don't look at it and say, okay, of this journal, these 10 of the 15 articles they published are good enough to be indexed in PubMed. They decide on a journal level. So if they say, okay, we're going to include citations from JAMA and PubMed, then every citation from JAMA goes into PubMed. It's not at that article. So you can't really rely on that. They do have some quality metrics I'm aware of when they decide whether to index a journal at all, and they kind of look at how long has it been around, what is their process, is it peer reviewed, and not everything in here is a peer reviewed article though. There's opinion pieces, there's editorials, whatever, but they do try to do some assessment of, is this a legitimate journal before they put it in there. But again, at that article level, it's not reliable. Now, the other thing you may be thinking of is something called PubMed Central, and that's really super confusing because the names obviously are so close. PubMed Central is just open access publications. So articles that are available free of charge, journals that are all open access, and there's also the NIH public access requirement. So that means if your research is funded by the NIH or one of their sub-agencies, you're required to deposit your paper into PubMed Central within a year of its publication. Now, obviously, you're required to put it there for grant reasons. That doesn't mean that you did a good job of the study. So yeah, its presence there is not necessarily a guarantee of quality, but that's where you want to start to really see what has been published, and then you do kind of have to narrow that down. One thing you do have in PubMed is you have some publication type limits. Let's just go back. This is really counterintuitive, so let me show you while I'm doing this. I hit the advanced link, and that's where I can see my search history. There's nothing that says history. It's weird. So for example, I just had it rerun this search. Now I don't have this set up the way I usually have it because I'm not logged into my NCBI, but what I can do is I have some article type limits over here. I can click on customize, and that'll give me more options, and those can include practice guideline or systematic reviews or different types of randomized controlled trial. So what I could do is I can go over here and click on randomized controlled trial, and at least that's got me down to the 16 that are really RCTs, okay? So that gives you something. You're not having to sort through every opinion piece, every little 5-person case series. You know, you can use those limits to get closer to what should theoretically be better evidence. Does that answer your question? Okay.
I wonder, are there any new developments in terms of small mobile electronic equipment where, for example, if I'm working in one of the units at the hospital and I've got a group of medical students and residents around me, and we come up with a question about something that's quite important and urgent.
Yeah.
What I would love to be able to do is just take out a handheld and have something printed out and distributed around the group.
Yeah.
And it would be a really advance in the training and the teaching of not only the people around me, but for myself.
Yeah.
So, but I don't think that exists yet, does it?
Yeah, I don't think we're where we would like to be on that. Part of it is it's just really hard to do all that evaluation and condensing. I will say, though, that some of these point-of-care tools like Dynamed Plus and like UpToDate, they do have apps for mobile devices. So you could have the app there on your phone, and you could do that quick look up into that summary kind of tool, and that would at least give you something. And so that's kind of a conflicting thing, right? It's not the absolute best level of evidence because it's somebody else's summary. You know, it's no comparison for you looking at it yourself and saying this is exactly right and what I need. But it's better than not looking at anything. And they are giving you references. Dynamed Plus actually grades the levels of evidence and tells you what it's based on, what they're recommending. So what I would do, I mean, I think that's kind of the compromise we're making, right? Because you don't have time in clinic to go through and look at 15 articles and figure out how well or poorly they're done and come, you know, that takes real time. So I think that's kind of the compromise position where we are right now, is to use sort of what's considered these point-of-care tools to get something rather, you know, which is better than getting nothing. It's not ideal, and I think a lot of people are still really wrestling with that. How do we get this exact information we need, knowing that it takes some time to kind of find it and process it and all that stuff. So you start somewhere where somebody else has already found and processed and that kind of thing. I'm sure there's a lot of room for improvement, though. Other stuff?
Well, thank you very much. I'd like to remind everyone to please fill out the CME surveys and turn them in before you take off today.
Thank you all.